did respond to some of the questions of the opposition, and I think when I close, I'll kind of talk about the purpose and the premise of the bill. Understanding, I realize this is a large policy discussion. We're at the end of the deadline for physical bills. That, yes, there's a lot more work. I will admit that, but yes, I'd be more happy to open up the questions to the members.
Good, thank you. So this is a work in progress. Let's open it to member questions. Vice Chair Nguyen, and just to be clear, I didn't announce this earlier. Normally Vice Chair Nguyen would be chairing, but she had to go to a meeting, so that's why I'm chairing.
And you're doing much better the job than I can.
Well, I don't know about that, but now you get to ask questions.
Thank you. I just have a couple, Mr. Chairman. One is, I understand that the Department of Managed Healthcare and the Department of Insurance are currently struggling with 4 major insurance mergers. Given their challenges, does it make sense to expand their authority over providers in this area? Or anybody can answer that.
That section was taken out of the bill.
Oh, okay, perfect, thank you. And then one other question is—
with regard to the providers.
Yes. The other one is, I know that the goal of ours is for state and federal is to promote integrated and coordinated care.
I agree, totally.
Of course, that helps to reduce costs and also increase quality of care. My concern, though, is if we disrupt the coordinated model and create disincentives to pursue effectiveness in the delivery system, can you help me understand the reasoning for adding these extra regulatory hurdles and prohibitions?
And the bill doesn't do anything to prohibit that. As a matter of fact, I totally agree. And I would even point out to CAPG, which does a wonderful job in how they do a delegated model. In California, they do a delegated model such that they use physicians, all providers, to have better quality, better outcomes, lower costs. However, I would pose the question, what happens if there is a medical group that has so much size that they become a monopoly? It is still incumbent upon us to make sure that that doesn't happen. And if you have the delegated model that is truly controlling costs, then it won't be a problem. But it's our responsibility as lawmakers to make sure that you as a consumer, or the consumer, if they're going to be paying for a health premium, that the consolidation doesn't turn into monopolization. And that's the consensus, and that's the essence of the bill.
Thank you.
Thank you. We'll move to Senator Pan.
Thank you, Chair. And I want to appreciate the author trying to address some issues. And I heard the testimony about consolidation. We've talked about dominant providers. Most of the testimony actually in support was around facilities. I heard from the Pacific Business Group about, well, you have hospital chains that are so large, right, that you basically, if you don't, and they say take it all or none. But I am concerned that at least some of the language said haven't had time to digest all of the amendment and so forth. So, for example, the requirement that a network vendor or payer includes in its network. So you can't have a requirement that if you have a network that you actually have to include the whole network. Now, I understand that what you're trying to do is say, okay, suppose I have someone who has a hospital chain, and they say you have to take all our hospitals or none of them. That's one thing. But the way this is phrased, so I guess my question is that I'll tell you that the dominant provider in my area is Kaiser, right? And so does that mean that Kaiser can't, now admittedly Kaiser only has one, but we can take another example, but that you can contract with one piece of it and not the other piece? Or let's say UC Davis. I practiced at UC Davis. We have a medical group. We have a hospital. And can a plan go in and say, well, I like your offices, your medical group offices, but I think Sutter or Mercy, Dignity has, their hospitals are cheaper. So what will happen is that, well, we only want to contract with these with the outpatient offices, but we don't want to contract with the hospital. But yet we've set up a system where, of course, our whole referral patterns, our specialists, all that is with, and even our record system is lined up with the hospital. And in fact, the hospital helped finance some of this too. And so that would cause a tremendous disruption. And I'm not, not that we don't talk to the doctors in the other hospital, but it becomes a bit of a challenge if we have a system, we have a health system that's set up to operate with each other and to coordinate and to improve efficiency in terms of communications and quality measures and so forth. But when they go negotiate the plan, they can't have a provision saying, well, actually, you take our health system. And I realize there's maybe situations where, and certainly, we're not the dominant health system in this area. So I hear what you're saying about, well, you have a player that's so big that they're squeezing out competition. But the answer seems to be, well, we're not going to let anybody then, that you can peel pieces off, and then to the degree that that may cause a problem. So I guess maybe, what about that situation? Suppose a plan says, you know what, I don't like UC Davis, they charge a lot for trauma. That's the usual complaint I hear. And so what happens is that what we're going to do is we want to contract with your clinics because we love your clinics and your doctors there, but we don't want to contract with the hospital. We're going to contract with another hospital who may not be on the same EHR, may not be on something else because they're willing to charge lower rates on trauma in their ER. I mean, that could be a real situation here potentially. And with this, and with this bill, or if it passed into law, say actually that's allowable, that because UC Davis is not allowed to say that you have to take the hospital with the clinics.
Senator, I'm not exactly sure that I follow your hypothetical here, but
The hypothetical is that you have a health system that has been organized together, right? We bought an EHR that connects.
Clarify that this bill is not intended to disrupt a clinical setting system where you have integrated models where they reduce cost.
Well, but the challenge is that actually it says requirement that a network vendor or pair includes network, one or any more providers owned or controlled affiliated with the contracting provider. So the medical groups are so affiliated with, and they're, but you're, at least the way I read this provision is you can peel one off from the other, or you can even peel off some clinics from the other. So that's my concern is that you have a system that you put together, and then you're allowed to peel pieces of it off because I don't like your trauma, I don't like your ER costs. Your ER is expensive. So I don't want to contract with your hospital in the ER, but I'm going to, because I want to go to another hospital, but I like your medical groups, your primary care doctor. So I'm going to take that piece, but then put the other, but then refuse to contract with the other piece.
so what we read this bill to do is really encourage competition in the marketplace. So we're encouraging parts of a whole system to, there's certainly nothing that outlaws collaboration, that outlaws integration. What it does do is prescribe anti-competitive behavior. And so if there is a particular hospital system that or a particular facility that's costing way more, and we don't want our employees to go there and get care, so we put them in a different tier, or we even cut them out, or we try to cut them out of the network. Right now, dominant systems in California explicitly, like by force, require us to include everyone within the system regardless of performance.
So I just want to clarify though,
We see
because I'll tell you that some people have complained in Sacramento, they thought UC Davis charges too much for trauma. And so one could say, well, we don't want to deal with this expensive hospital, but we like the other piece of it. That's the problem I'm getting at. And this, at least the way I read the bill and the language, it allows health plans to do that, and it doesn't allow the health system to say, no, we won't contract with we won't let one piece, It basically forbids the health system to go and say, you can only contract, we only want to contract with your primary care group, your medical group, but we don't want to contract with the hospital part.
Okay, as opposed to having a rambling dialogue here, I think, did the opponents want to address that question?
Yes, through the chair.
Yes.
So David Gonzalez again on behalf of CAPG. Again, we're digesting a lot of these provisions, but reading through some of these provisions, from our perspective, it is a little bit ambiguous in terms of how a health plan can pick and choose within a group which providers they want to use, and that's the whole point of the integrated delivery model. An example that I use is that a lot of times the plan will delegate to the medical group some of the administrative provisions. For example, the provider directory legislation that Senator Hernandez authored, Senate Bill 137, timely access, those responsibilities get delegated to a group. And so that overhead gets absorbed by all the providers. But if the health plan can come in and then just contract with some of those providers, it's going to disrupt the market and cause a dislocation within the group and a disincentive to actually belong to a group. So it's actually a disincentive to have that coordinated care. That may not be the intent, and I may be misreading that provision, but as currently drafted, the way we read it, it would be disruptive to the coordinated model, which seems to be the direction not only of this state, but of the federal government as well. And
Thank you.
In terms of the anti-competitive, there are provisions of law that address those issues, anti-monopoly provisions that are pretty substantial.
So if we can just have, perhaps Sarah may want to respond to that.
I think I appreciate your question very much so. And I think part of what this gets at is that it doesn't want to, I don't think this legislation wants to interfere too much with negotiations between two parties, which is the facility, the medical group, and the health plans. But it is banning things that get into anti-competitive and antitrust. So it would be, the way I would read it is that the contract, and no contract could say you have to have everything in our system, but it still allows for negotiation. My understanding is that it still allows for negotiation between a plan and a system to say, like they do now, what's going to be in, what's going to be out. So I would hope that this is just putting in a provision that prevents anything anti-competitive and doesn't prevent negotiation between two parties.
Thank you. Senator Pan, other questions?
Well, it sounds like that needs to be more work done. I appreciate what you're saying, and I understand your intent is not that, but just the way I'm reading it. And then the other, just one other question is the provision F about incentives, and again, I understand about not having incentives to have people go out of network and so forth. But I just want to clarify that, sometimes people have rare conditions. As a physician, and I see them as a primary care doctor, I may tell, I feel like my duty as a physician is to give the best advice possible, and suppose the best person to take care of their condition is a specialist that's not in the network, that it's a very rare condition. Maybe it's go to Stanford. That's the people who know how to take care of that. Is that going to be a problem at all? I don't know where that fall under incentives or encouraging or something. I just want to be sure that we're not muzzled from being able to tell patients where they should go for their best care. Obviously, we're not, I know you're trying to stop systematic, right, sending people out of network. We don't want to do that, but also being sure we have freedom to communicate with patients where we feel the best, the most appropriate care could be taken care of. So.
Thank you, Senator Pan.
Thank you.
I'm going to go to other questions on the panel. Senator Roth.
Well, thank you. I'm not sure that I have a question, just a comment. This clearly appears to be a moving target to me, and it's moving very fast. I sort of pride myself in taking the time to try to understand what bills are and know what I'm doing when I cast a vote. And frankly, I have to tell you that I haven't had sufficient time to analyze this, and I certainly haven't had time to look at the amendments. I will tell you that I come from an underserved area of California, inland Southern California. I'm concerned about the impact of the affiliation language, affiliations between hospitals and medical groups. I'm concerned about the tiering provisions that I think were addressed. I had to go to a meeting over on the other house, so I missed part of the presentation. Maybe some of these issues were addressed. I'm concerned about provisions regarding incentives. We all want lower cost of health care, but frankly, I need to assess the impact of this on the medical community in the area that I represent, because we represent not only individuals, but businesses and healthcare facilities and medical groups. And I don't know what the answer to any of that is. If necessary, I have the utmost respect for my chair and his expertise. If necessary, I will take the action to move this out of committee today. But I'm going to be doing my homework with my constituents and the healthcare providers in the district that I'm privileged to represent, and we'll complete that before we have to cast another vote on this in the future. Thank you.
Thank you, Senator Roth. And I'm just going to make a comment, and then we'll turn it back to the author, assuming if there's not other questions. This is ambitious. We've received just today work on the amendments that I think does reflect the author's good faith and intent to work with opponents and proponents, and that there has been some narrowing, and we've heard from the opposition appreciation for some of the proposed amendments in the mock-up, and that it is a continuing work project. So I think we all respect that. For me, the lens, that there's multiple stakeholders. We have plans, providers, doctors, hospitals, and patients. And while we have patient representatives among the proponents, the lens that I will ultimately study this bill through, I respect the rights of all stakeholders, be they businesses, providers, whomever, but it's patients who we seek, and I believe the author seeks to protect from the adverse impacts of anti-competitive policies. That's the broad objective. And so I'm going to be supporting the bill today. I would entertain a motion from a member of the committee before we allow the chair to provide closing comments. Is there a motion? This is do pass as amended to appropriations with the representation from the author that it's a work in progress. I'll move the motion. We have a motion to pass as amended to appropriations. Senator Hernandez, would you like to close?
Yeah, thank you, Mr. Chair and members. I'd like to first start off with the comment you made that this is ambitious. Yes, it is. Let me put into context of the conversations I've had and the thoughts I've had and with my staff, the stakeholders, the opposition, and how we're going to address this. So if we look at what happened immediately after the implementation of the Affordable Care Act, there was a lot of uncertainty. Everybody that's here, providers, plans, groups, hospitals, nobody knew what was going to happen with its implementation. Then there was, because of the change and the markets were starting to react, there has been a lot of change. And the changes have occurred. Is it good or is it bad? And I'm starting to question is you see Centene, one of the largest health plans in the United States, purchase HealthNet. You see CareFirst being purchased. Yes, you're seeing medical groups form because of uncertainty. You're seeing hospital systems buy up hospital systems. You're seeing foundation models. There's all this discussion. And the question is, there is consolidation for a reason, for scale, so that they can compete in the market, so that they could have enough resources. But here's what I would hope that what this does is to do exactly what the good actors are doing, exactly what CAPG does, which is a coordinated system, control cost, and provide the consumer with high-quality health care at an affordable cost. So the question I posed to my staff when we did our strategic planning, is that good? And that is good. But what are the unintended consequences if a system becomes so large and there's monopolization? And if there's monopolization, that could be bad because that could drive up cost. And then we have as a responsibility to make sure that that doesn't happen. For example, if a large telecommunication company wanted to buy up another one, you have regulations at the federal level to make sure that there's not going to be a monopolization and that that's not going to be passed on to the consumer. The conversation is not about whether they provide good telephone service. The conversation here shouldn't be about if they're going to provide good service. The conversation here is this going to have an effect on cost unduly and inappropriately for the consumer? That's where it is. So yes, it is very ambitious. I realize this is a big piece of legislation, and I am willing to work with all the stakeholders so that we get at the root of what I think I want to accomplish in this piece of legislation. So with that, members, I respectfully ask for an aye vote.
Thank you. We have a motion to pass as amended to appropriations. Clerk, please call the roll.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Nguyen, no. Hall. Mitchell. Mitchell, aye. Monning.
Aye.
Monning, aye. Nielsen. Pan, Roth, Wolk,
So it's 3-1. We'll hold that open for absent members. And Mr. Chair, what's your pleasure? I know you have other
We can
bills.
do an order. So 960, I believe, is next, or whatever the order is.
Yeah, next item 2 is SB 960.
Thank you, members. This bill will expand access to reproductive health care services through the use of innovative technology that connects patients with healthcare providers more efficiently and cost-effectively. Telehealth is expanding. It's a virtual part of our healthcare system that increases access to care and lowers the cost of services, especially in rural and underserved areas of our state. Planned Parenthood developed a mobile app that patients can use to request tests for certain conditions and to request hormonal birth control without requiring an office visit. However, Medi-Cal reimbursement for telehealth services is limited to only a few fields of medicine. This bill will enable certain reproductive services available to patients through health centers be accessible safely and effectively when delivered through telehealth. We have been working with the health plans and will continue to do so to come up with a way that this bill will work for them while still ensuring that Medi-Cal enrollees have access to these services. By offering the amendments before you, we hope to show a good faith effort towards working on an agreement. Members, at this time, we have an increased insurance coverage for millions of Californians. This bill ensures that low-income women seeking reproductive health care services, regardless of locations, can receive the care they need the most efficient way possible. Members, I have individuals who like to speak in support of the bill, and I respectfully ask for an aye vote.
Thank you, Mr. Chair. Before we go to witnesses in support, there's a lot of interest in this bill as well. In the interest of time, we are going to ask you to use 6 minutes among the three of you. Please proceed.
Good afternoon, Mr. Chair, Senators. Gregory Kramer on behalf of Planned Parenthood Affiliates of California. We're the proud sponsor of Senate Bill 960. The bill provides for Medi-Cal and Medi-Cal managed care plans to reimburse delivery of reproductive health care services for all patients by store and forward, as well as for telephone and email for existing patients. Expanding health care for reproductive health benefits patients and increases access to care for underserved communities. Many of our patients face obstacles in accessing care, both in the inner city and in rural areas. Oftentimes, patients struggle to take time off of work or of school or to find childcare in order to seek care for themselves. Others have difficulty coordinating transportation to health centers. The delivery of routine services such as for sexually transmitted infection tests via telehealth is efficient and protects patient confidentiality. For some patients, the stigma of potentially contracting an STI may be humiliating and may deter them from immediately seeking care. With telehealth, patients may initiate an STI test from the comfort of their home 24 hours a day through a secure network built to protect patient information. SB 960 provides that services, including STI tests and other reproductive health services via telephone or email, would be reimbursed similarly to in-clinic services. And in doing so, this bill removes barriers to care and protects California's most vulnerable residents. With me is Beth Parker, Chief Legal Counsel of Planned Parenthood, to answer any technical questions and discuss the role of telehealth at our 115 clinics.
Thank you very much. Next.
Yes, Beth Parker. So SB 960 seeks to expand reimbursement for the delivery of reproductive health care services for new technologies that are increasingly being used to expand access to underserved communities. Planned Parenthood is sponsoring this bill because we provide reproductive health care to close to 1 million patients, and over 85% of these are low income who access care through either the Family Pact or Medi-Cal managed care. And there is no current method of reimbursement for low-income patients if these services are offered through a mobile app or web browser such as telehealth or telephone or email, which is increasingly the way that patients want to access services. So last June, we launched a mobile app, PP Direct, to offer testing and treatment for sexually transmitted infections through the privacy and convenience of one's home. And tomorrow, actually, we're adding birth control and urinary tract infection treatment. Currently, these services are cash pay only, but we would like to extend these services to all Californians who need them, not just those who can afford to pay them out of pocket. Low-income Californians should be able to take advantage of these new technologies just like anyone else.
In fact, low-income Californians often have the greatest difficulty accessing care because of the paucity of Medi-Cal providers and the cost of taking time out of work or school and arranging for childcare. California already permits reimbursement for teledentistry, teleophthalmology, and teledermatology by store and forward technology, where the patient provides detailed medical information via an app, and a licensed medical provider reviews it at a later date at a distant site and then provides advice or treatment. There's no reason that certain reproductive health services, such as the provision of birth control to reduce unintended pregnancies or the treatment of sexually transmitted diseases, which is a growing public health concern in our state, cannot be added to this list. As to telephone and email reimbursement, patients are increasingly seeking to get their medical questions answered by calling or emailing their providers. It's more efficient for everyone. It increases access and reduces wait time. For routine reproductive health care services, there's no reason to take time off of work and travel to a health center to have questions answered. In fact, our smallest affiliate told us just last week that their call center is now receiving 3,000 calls a month from patients who have specific questions about their care, and they have hired a panel of providers so they can direct those calls directly to them, but currently there is no method of reimbursement. As to email, our affiliates would like to offer our patients the option of emailing our providers directly through patient portals, just like Kaiser does, but without a reimbursement model, they cannot consider opening up this modality. In sum, new technologies and patient comfort with them are offering tremendous new opportunities for providing certain healthcare services more efficiently and conveniently. Medi-Cal and Medi-Cal managed care plans should reimburse for these modalities. Thank you. We urge your support.
We have about 1 minute left.
That's fine. I don't have much to say on this one, other than my name is Kathy Dressler, and with the Children's Partnership, we are longtime supporters of telehealth in teledentistry and many other venues. We think it removes barriers, and for that reason, we support this bill.
Great. Thank you. Thank you all. Now we'll move to witnesses in support. Please name and organization.
Thank you. Amy Durbin with the California Medical Association in support. Thank you.
Michelle Gibbons with the County Health Executives Association in support.
Brian Ortiz on behalf of the ACLU of California in support.
Jonathan Nelson with Icebreaker Health in support.
Jody Hicks with the California Academy of Family Physicians in support.
Good afternoon. Fred Noor with Stanford Healthcare in support.
Thank you. And I'd invite witnesses in opposition to please come forward.
Good afternoon. I'm Jennifer Alley with the California Association of Health Plans. We actually have an oppose unless amended position on this bill. Currently, Medi-Cal policy allows for Medi-Cal managed care enrollees to seek out-of-network services for reproductive health services. So what this bill does is it's expanding the modality in which those services can be delivered by my members who actually support and utilize telehealth to build networks within their contracts already. But our concern with this bill at this point is that there's no structure or framework for the reimbursement rates and the reimbursement policies to be developed in Medi-Cal to make sure that they're included in the Medi-Cal managed care rate development with the department. And that's a significant issue for us because as new Medi-Cal benefits are implemented, it usually takes about 2 years for the rates to reflect that. And so we're in active discussions with the sponsors and the chairman's staff, and we're in the process of figuring out exactly how that will work. Thank you.
Thank you. Seeing no others, any others in opposition who want to step forward? Seeing none, members, questions? We have a motion. This is to do pass as amended to appropriations. Senator Hernandez, would you like to close?
Just ask for an aye vote.
Ask the clerk to call the roll.
Hernandez? Hernandez, aye. Nguyen? Hall. Mitchell. Mitchell, I. Monning.
Aye.
Monning, I. Nielsen. Pan. Pan, I. Roth. Roth, I. Wolk.
That's 5-0. We'll hold that for absent members.